Hello, I'm Dr. Judy Salerno, President of the New York Academy of Medicine. I'd like to welcome you to our virtual summit on nursing home infection prevention. This summit is presented in partnership with the Yale School of Nursing, with generous support from the Saraya Company. I want to say a brief word about the New York Academy. As some of you may know, the New York Academy of Medicine has been working to improve communities' health by driving systems change for over 173 years. Grounded in a vision that everyone should have the opportunity to live a healthy life, NIAM generates knowledge to inform policy and programs, works collaboratively with local partners on community-driven solutions, and engages the public to achieve its mission to drive progress toward health equity. One way that we're working toward our mission is through examining the stark inequities in the COVID-19 pandemic and examining how the disease affects different groups of people in different settings across the US and around the world. According to the US Center for Disease Control and Prevention, approximately 2.1 million people in the US live in nursing homes and residential care facilities, representing only 0.6% of the US population, but residents in such facilities account for 42% of all deaths from COVID-19. So at this summit, we will hear from an esteemed panel of experts who will share their perspectives on the regulatory, research, clinical management, personnel, and human rights aspects of preventing infections in nursing homes across 3 continents. And we will explore ways how we can lower the infection and death rates for our nursing home residents and staff. If you'd like to ask a question or make a comment at any time during the program, click on the bubble icon labeled Q&A in the bottom center of your screen. Your questions will be shared only with the panelists, and we'll have time for them to respond after the presentations. Now I'd like to turn it over to Mario Rubano, an intern and a public health student at the Center for Healthy Aging at NIAM. Mario.
Thank you, Judy. So today I'm excited to share an overview of the research that we've done on infection prevention in nursing homes. This research, along with the information gleaned from today's virtual summit and a series of qualitative interviews that we are conducting with nursing staff in New York City-based nursing homes, will be provided to our colleagues at the Yale School of Nursing, who will use this information to create an educational toolkit for nursing home staff in the U.S. and slide. Through our scan of the literature on nursing home IPC practices, we identified 5 primary areas of focus: staffing and resource availability, training and knowledge of infection control practices, quality of life impacts, organizational culture, and external influences, including regulations and reporting. This brief overview aims to summarize the findings as well as introduce key concepts and terms that will be used throughout today's summit. Next slide. In our research, we focused primarily on both licensed and unlicensed nursing staff due to their frequent and prolonged interactions with vulnerable residents. Adequate nurse staffing levels have been found to play an important role in reducing the transmission of healthcare-acquired infections, or HAIs, in the nursing home setting, and is linked to better outcomes with infections such as urinary tract infections, UTIs, and bed sores. Numerous workforce studies have indicated that the nursing shortage has reached crisis levels, with some 80,000 nurses estimated to leave the profession just this year. Inadequate nurse staffing has been found to be a primary driver of both job dissatisfaction and interference with provision of care. Next slide. Nurse tenure in a facility has been linked to decreased falls in UTIs and allows for more accurate monitoring of the often subtle presentation of infection symptoms in the nursing home population. Lack of benefits and poor pay create the conditions where nurses work multiple part-time jobs in multiple facilities. These staffing exchanges increase regional threats to infection control. The average US nursing home has staffing connections to 7 nearby facilities. Eliminating these connections could result in a 9% decrease in COVID-19 infections. Next slide. The CMS final rule of October 2016, covered in more detail in Section 5, included a staffing dimension mandating every nursing home certified by the Centers for Medicare and Medicaid Services, CMS, to maintain a staff IP, or infection preventionist, who oversees the IPC program and related initiatives. Nursing homes employing IPs with specialized infection training or certification in nursing home IPC are 5 to 13 times more likely to have a stronger IPC program. Nursing home IPs are also more likely than acute care IPs to play multiple roles in a facility, such as the employee health director or the director of nursing. Next slide. The coronavirus pandemic has exposed nursing home staffing crisis in stark terms. In this context, nursing homes with higher total RN and CNA hours were correlated with better containment of the virus and decreased mortality. More specifically, in facilities with at least one confirmed case, every 20-minute increase in RN staffing per resident day was associated with 22% fewer cases. Furthermore, an April 2020 survey of 56 nursing homes from around the US showed that 83% expected significant staffing shortages. Next slide. Certainly, we've all become acutely aware this year of the importance of access to personal protective equipment, or PPE. Before COVID-19, 15% of nurses had reported an inability to disinfect their hands during active care, as hand rubs were unavailable in resident rooms. Ready access to soaps and an increase in the number of hand washing sinks per 100 residents have been shown to reduce the spread of a variety of infections in nursing homes. Similarly, the availability of private rooms is a critical element of an effective IPC program to offer appropriate isolation and cohorting practices. Next slide. Early national data showed nearly all nursing homes struggling to maintain some element of PPE, with nearly all in need of N95 respirators, gowns, face and eye guards, and alcohol-based sanitizers. 20% of nursing homes reported being under-resourced 3 months into the pandemic. Interestingly, for-profit nursing homes were more likely to report PPE shortages, and nursing homes with healthcare worker union representation showed a 30% relative decrease in patient mortality due to COVID. Next slide. The cornerstone of an effective IPC program is staff training in the basics of hand hygiene. Rigorous hand hygiene practices have been linked to reduced mortality and a decrease in the use of antibiotics. Yet, despite the wealth of evidence, nursing homes still struggle to maintain adequate levels of hand washing. Significant gaps in knowledge exist. A number of qualitative studies on hand hygiene training and knowledge have shown alarming levels of misunderstanding for both licensed and unlicensed personnel, and even amongst IPs. Next slide. Quantitative studies have also reflected the knowledge gap. A look at statistics from a recent knowledge assessment are cause for great concern. Only roughly a quarter of nurses and aides knew how to rub their hands while washing. Physicians and physical and occupational therapists performed even more poorly. Alarmingly, 100% of nursing homes involved in the assessment had hand hygiene training programs in place. Next slide. One of the many goals of the final rule is to raise the minimum education requirements of IPs. This is a necessary aim, as IPs with specialized nursing home training are linked to decreased infection deficiencies. Effective staff training weighs timing, frequency, interactivity, and individual tailoring. In fact, infrequent and irregular training has been deemed an environmental risk factor for infection. Success has been found in educational programs that bundle hard technical skills like proper catheter care with soft socio-adaptive skills like leadership, communication, and team building. Next slide. Many IPC practices for nursing home care have been imported from acute care models without much consideration given to the specific needs of an older, more vulnerable population receiving long-term care. Shared and congregate spaces are characteristic of essentially all nursing homes and contribute to the social well-being of residents. By definition, the facility serves a dual role of primary residence and care provider, which brings with it a unique set of challenges. Next slide. Isolation measures can often be overused out of fear of spreading an infection. This practice may also produce negative stigma for the isolated resident. Furthermore, strict and prolonged isolation procedures during the COVID-19 pandemic have given rise to touch starvation, the limiting or complete elimination of skin-to-skin touch, which can increase stress, anxiety, and depression. Next slide. Organizational or institutional culture has been defined as the accumulation of invisible, often unspoken ideas, values, and approaches that permeate organizational life. Organizational culture has been found to play an important role in the success of IPC programming. The emerging consensus is that isolated interventions aimed at improved hand hygiene will demonstrate little effect if not supported by a shared attitude that holds proper hygiene as a resident safety priority. Next slide. 4 themes have been identified for effective institutional interdisciplinary culture change: linking IC adherence to patient outcomes, generating group accountability and ownership, taking action for the collective good, and facilitating teamwork. Notably, these themes eschew a narrow, purely individual focus on IPC behaviors and instead seek to broaden the understanding and the impact of decisions on organizational culture as a whole. Next slide. Nurses in nursing homes report higher levels of job dissatisfaction and burnout than any other setting that employs nurses. Poor working environments increase the likelihood of burnout. A good work environment is one in which nurses have enough staff and resources, supportive managers, and a sense of input into organizational affairs. Next slide. 95% of burned out nurses and 83% of dissatisfied nurses have reported at least one missed care event during their most recent shift, compared to 72% of nurses who did not report either burnout or dissatisfaction. In the context of IPC, a single missed care event could include poor patient surveillance of early symptoms of an infection, or neglecting to change a wound dressing while rushing to complete other tasks. Next slide. As some of our guest speakers for this event will be touching upon national and international regulatory frameworks, this slide simply provides a bird's eye view of the major steps that led to the implementation of the 3-phase CMS final rule, and provides a perspective on the pace of administrative and bureaucratic initiatives. Perhaps most important to note is that the genesis for this initiative can be found in international cooperation. Multi-drug resistant organisms, or MDROs, are an established and rapidly growing threat to global health. In today's increasingly globalized world, HAIs and the monitoring of antibiotic use will require sustained collaboration. And it is in that same spirit that we celebrate today's opportunity to bring national and international perspectives to the shared challenge of infection prevention and control in nursing homes. Next slide. And so switching gears, I want to briefly tell you about the interview portion of this project. The goals are to explore real-world IP experiences from the clinical staff themselves before and during the pandemic. as well as to learn about the facilitators and barriers to IP practices from those who know them best. We're interviewing nursing staff from New York City-based nursing homes in confidential, semi-structured interviews over the course of 3 months. Next slide. As you can see, we're asking a variety of questions about policies, pandemic experiences, and anticipated needs. Next slide. In 2021, a team at the Yale School of Nursing, led by Dr. Carmen Portillo, will synthesize all of this information to create a publicly available toolkit that will be used by nursing homes around the world. And so thank you very much for your attention. I will now pass it over to Ilana Kiefer to introduce our first guest speaker.
All right, thank you so much, Mario. As your intern supervisor, I am particularly proud of the work that you've done on this project and the presentation you just gave. My name is Ilana Kiefer, and I am the program officer at the Center for Healthy Aging at the New York Academy of Medicine, and I will be moderating the rest of the program. And so we are just so lucky to have, I did the math, so we have 5 experts across 4 time zones in 3 different continents. So we're going to take you all around the world today, and we're going to start with Dr. Nimalie Stone, who is at CDC, the Centers for Disease Control and Prevention.
Wonderful. Thank you so much, Ilana, for that kind introduction and the opportunity to participate in this wonderful symposium and talk just briefly about our experience with COVID-19 in U.S. nursing homes. Next slide, please. Just want to mention that I have no conflicts to disclose and that this presentation reflects my opinion and not necessarily the official position of the CDC. Next slide. I'd like to start by expressing my personal gratitude and our gratitude on behalf of public health to all of the nursing homes and assisted living staff for their dedication and commitment to their residents and families. We'd also like to thank the hundreds of providers who have shared their experiences with CDC teams in the field and mention that the strategies and best practices within our guidance are informed by the lessons that we've learned while working with them. Next slide. Going back to the beginning, at least in the US, we had our first confirmed case of COVID-19, which at the time had a different name, back in January 21st of 2020, and it seems like a lifetime ago. It's hard to think back on that time when we had such little information about the SARS-CoV-2 virus and how it spread. By mid-February, we were starting to get reports of difficulties in obtaining personal protective equipment, and I remember hearing from nursing home colleagues about shortages that they were already facing. And then on February 28th, we heard about the first nursing home resident to be confirmed with COVID-19. Next slide. And that outbreak signaled the beginning of a devastating experience as we saw SARS-CoV-2 take advantage of the many vulnerabilities in the long-term care setting, from the fragile residents to the infrastructure and supply challenges facing staff and centers trying to respond. For many of us working to support infection prevention and resident safety programs in nursing homes, perhaps how this pandemic unfolded was not unexpected, but it was and continues to be painful and heartbreaking. Next slide. From that moment onwards, we have seen a tremendous number of policy and regulatory measures focused on nursing home infection prevention and outbreak tracking activities. Given the federal oversight that the Centers for Medicare and Medicaid Services, or CMS, has over nursing homes, many of these infection prevention and control efforts have been driven by them in close collaboration with CDC. Next slide. As a result of one of those regulations, we now have over 15,000 nursing homes enrolled in the CDC's National Healthcare Safety Network, which is a large healthcare-associated infection reporting system for healthcare facilities across the country. And they've been reporting COVID-19 cases and deaths among residents and staff since the end of May. These data are updated weekly and publicly posted on the CMS data website that is listed at the bottom of the slide. And I do believe the slides will be posted following the seminar. And as of last week, COVID-19 case rates among residents was increasing in 32 states, and roughly 2/3 of facilities were experiencing recent trends and recent cases among staff or residents. Next slide, please. These graphs show trends of COVID-19 rates among staff and residents since the NHSN reporting began. And you can see how the two curves mirror one another, with the peak in resident cases usually trailing the staff cases by about 1 to 2 weeks. And this really illustrates how strongly staff risk for SARS-CoV-2 in the community leads to resident risk in the centers where they work. And unfortunately, right now the rates are higher than we've seen at any point prior in the pandemic. Next slide. As I mentioned earlier, all of our guidance and implementation materials for preventing COVID-19 in nursing homes and other long-term care facilities have been informed by the experience of providers in the field. And we continue to review and update these documents as we learn with and from our provider, community, and academic partners. Next slide. This is the framework that we have used to promote COVID prevention and response efforts. We're recognizing that keeping COVID out is an incredibly challenging proposition, especially when community cases are on the rise. But it highlights the critical importance of early detection and diligent attention to infection prevention practices critically necessary to reduce the transmission of virus from staff to residents. Next slide. We have seen incredible importance of leadership and culture in facilities that have been the most successful at sustaining their prevention efforts and clinical operations. Maintaining resilience in the long-term care workforce must be a top priority in communities and organizations. And not surprising, this pandemic has put a bright spotlight on the critical role that infection preventionists play in maintaining a safe environment for residents, families, and staff. Next slide. We have also seen the expansion of relationships between the long-term care provider community and state and local health departments. I'm really hopeful that some of the communication paths and collaborations that have developed as a result of this pandemic will continue to be sustained long after our fight with SARS-CoV-2 is over. We need to recognize and support the important contributions the long-term care provider community has in the delivery of safe healthcare in this country. Next slide. So with that, I'm going to thank you again for the opportunity to participate in this very important discussion. I look forward to learning from my co-panelists and hearing your questions and comments. Alana, I'll turn it back to you. Thank you.
Thank you very much, Dr. Stone. And now we'll turn to our next Dr. Stone, Dr. Patricia Stone at the Columbia University School of Nursing.
Great. I'm very happy to be with you today to talk about research on infection prevention measures in nursing homes. So next slide, please. You can see this is some research that we've been doing for quite a few years, and you can see some of my research team and collaborators are on the panel tonight. Some of our first things we wanted to do was qualitatively explore the phenomena of infection prevention and control in nursing homes and describe the incidence of HAIs and infections occurring in the nursing homes. This is all pre-COVID. And then describe the processes that were, the infection control processes that were occurring. Next slide, please. So our methods for the qualitative, it was structured open-ended interviews. We actually went to the nursing homes to visit them. We did a national survey of nursing homes, and then we linked it with national data sets. The minimum data set is mandated for nursing homes to do. The residents' clinical assessments that are done on admission and when quarterly or when there is a change of assessment or a change of status. CASPER is facility characteristics, things like staffing, and as well as CMS deficiency citations are in there. And then Medicare claims allowed us to look at people that had infections and track them into the hospital. Next slide, please. So the qualitative results, we went to 10 nursing homes across the United States and interviewed 73 employees. And the 5 things, it's somewhat similar to what NIAM's finding now, were residents' needs. And that's the tension between the facility being the resident's home and the need for effective infection prevention and control procedures. Roles and training, many employees involved in an infection control program had multiple other responsibilities, and frequently they lacked formal training. Most of them were nurses, but running the infection control program just came with another job, being a supervisor. Using infection data, people said they used their infection data, but their surveillance methods and definitions that they used were all over the place. It was not consistent across. I'm here very happy to hear Nimalie talking about external resources and communications, because the nursing homes at that time were really looking outside for their information and support. They would look at their local health department, state health department, or the CDC, or their local hospital system, where there might be a well-qualified Department of Infection Control. Everybody said they focused on hand hygiene, but how they did it was often informal. They'd say like, oh, well, we monitor staff compliance. If I see somebody coming out of a room that hasn't taken off their gloves. Next slide, please. So when we used the MDS to look at the trends in HAIs or infections out of nursing homes, in the middle of this work, we were using 2006 to 2013 MDS data. In 2010, they went from MDS2 to MDS3, and you can see the line right there. Pre-2010, everything was going up. After 2010, with the new definitions and the new MDS3, things did decrease. And the prevalence of UTI, MDRO, and wounds all were decreasing, and viral hepatitis increased. Next slide, please. Nonetheless, this can show you across all the years, UTI and pneumonia were the most common infections. And based on these data, we estimated that there was about 1.13 to 2.68 million HAIs occurring in nursing home residents annually. Next slide, please. And then these infections are very important. We looked, using our Medicare data, we looked at a transfer caused by infection, and that's the infection was the primary diagnosis present on admission or with an infection, and the infection can be anywhere on one of the 27 diagnosis codes that the hospital admission record could have. And caused by infections, between 35 to 40% of all transfers to hospital are caused by infection. With an infection, it was 57 to 61%. Next slide, please. So we did our first survey of nursing homes back in 2014. We just had under 1,000 nursing homes returned their surveys, and we linked it to that CASPER data. Again, triangulating with our qualitative data, person in charge of infection prevention had multiple hats. Citations in the deficiency citations were that CMS gave out in their inspections were related to the experience of the person in charge of the infection control program. Less than 3% of those infection preventionists were certified. Next slide. When we looked at comprehensive antibiotic stewardship policies, we found that they were very rare. But we did, IP training was related to having a comprehensive antibiotic stewardship policy program. Next slide, please. So we resurveyed nursing homes in 2018, just less than 900, this time 900 surveys with a 50% response rate. We had those same measures of the infection control program and training of the IP. But then we were also interested in palliative care processes that were occurring, the infection management processes for those at end of life, and the integration of palliative care and infection management at end of life. Next slide, please. So the antibiotic stewardship, there's 5 policies, outbreak control, 7 policies, UTI prevention, 7 policies. And for those 3 policies, we calculated standardized intensity indices based on how many policies were in place. Next slide. So you can see that everything improved from 2014 to 2018. Antibiotic stewardship went up. As we already heard, it became mandated that the US nursing homes have an antibiotic stewardship program. Only 65% of the ones said they did. Outbreak control, that went up too. Things were getting better. And urinary tract infection prevention, it's been a long day, also went up from about 50% to 56%. Next slide, please. Drilling down to outbreak, because we're in a pandemic, you can see there was no difference in having having policies about being able to cohort infected residents. But more nursing homes reported they could confine the resident to their room. They had rapid diagnostic methods for different types of infections. They had policies about closing the facility to a new admission. They had policies about instructing infected staff to stay home, administering prophylaxis, mainly, well, for influenza, and policies about quarantining units. So things were getting a little bit better, thank goodness. Next slide, please. The IP training, so we had 2.6 or just less than 3% certified in infection prevention. That went up to 7.43. Look on the right side, and you can see where they got their training in the middle. But if you look on the right side, still 44% of the IPs, or the person in charge of the infection control department, had no specific infection control training, and that we need to change that. Next slide, please. So I'm going to talk a little bit about integration of infection management and palliative care. Next slide. I don't have time to go through how we developed this. You can look at the citation, or just trust me, we did a factor analysis, and we had very good vignettes, and we came up with a composite measure and 3 subscales about integration of infection management and palliative care: involvement, advanced care planning, and routine practices. And you can see the Cronbach alphas and the mews, or population means. And the population means for these were fairly low: 73 for involvement, 34 for advanced care planning, and 31 for routine practices. All were small positive correlations with other infection management and palliative care indices. There was few associations between regional, state, or nursing home characteristics. Next slide, please. So what do we think of this? This work has had some policy impact. This summer, I was very happy to be on this commission that CMS did about safety and quality in nursing homes. Can't go over the whole report. There's 10 themes, 27 recommendations, and 100 action steps. But having a full-time trained infection preventionist was something that I cared about and made sure to talk about and got in there. Palliative care and integration, that is providing comfort care for nursing home residents with infections. It's not mentioned in the report. And I didn't feel like I had enough evidence to really support an evidence-based recommendation. And indeed, another systematic review of 21 COVID-19 nursing home guidance documents from around the world, they reported that most all these documents focused only on infection prevention and control, and very few sentences about palliative care. Next slide. So what does this mean? Even before COVID-19, infections were occurring frequently in nursing home residents. I hope that they won't occur so frequently after. Infection prevention and control in nursing homes is evolving very quickly with COVID-19, but we do need to make sure we have good regulation in there. Infection management is suboptimal, and treatments of bringing these people to the hospital, putting them on a ventilator with IVs, is often inconsistent and burdensome and inconsistent with their palliative care goals. We need comfort care. It's still unclear to me how best to implement and coordinate good infection prevention, palliative care, and integration of the two, infection management and palliative care. And we need strong evidence-based recommendations. Next slide, please. I need to thank our funders, the National Institute of Nursing Research. I think they were happy also that they've been doing some things in infection prevention and put us on their website. Next slide, please. And of course, I want to thank a fabulous interdisciplinary team. These things do not happen by themselves. And all the nurses who have participated in our research over the years, thank you very much. I look forward to questions and talking to you later.
Thank you, Dr. Stone. And as she said, please do put your questions and comments in the chat. There's a little bubble on the bottom, and we welcome them. We are taking them even though you cannot see them. So next we have Dr. Lisa Hall from the University of Queensland in Australia.
Thanks, Alana. It's my absolute pleasure to present to you an Australian perspective of COVID-19, aged care, what went wrong, and also a little bit about some take-home lessons from a lot of our research that's been undertaken in hospitals and what some parallels might be. Next slide, please. So firstly, just to give you a bit of perspective, we've actually done very well in Australia with managing the COVID-19 pandemic. So we recognized it was a pandemic in mid-January. We closed our borders. We put in place a lot of national agreements. We went into lockdown late February, early March. And things were traveling very, very well until we started to see a spread in our nursing homes. And really then we had a second wave in Victoria that's got into nursing homes and was devastating. And I think this is a really interesting thing to look at, because overall in our total population, we've had almost 28,000 cases of COVID-19 for our whole country, 908 deaths, but really 75% of our deaths have come from aged care, so people living in nursing homes. And to me, that is really concerning and worrying. And when I tried to pull the numbers from the government websites, it became, even more confusing, because the staff infections and the resident infections are all reported separately, which I think is clouding our view of what's actually happened. So we've had 223 outbreaks across almost as many facilities, and practically the same number of residents and as staff infected, which parallels very much with what Dr. Nimalie Stone was just mentioning, with that parallel with staff becoming infected and then bringing it into the nursing homes and infecting residents. Next slide, please. So really, what went wrong with our nursing homes, given we were so well placed with our other facilities and our general population health measures and our public health contact tracing and everything else was set up really well? Well, in a way, I think we had the perfect storm. And there's been quite an interesting editorial recently in The Lancet about the Australian aged care experience with COVID. And looking back, in the infection control community, we've been raising alarm bells around infection control in nursing homes and aged care for a long time. In 1997, the government actually decided to move away from providing aged care themselves into a free market model, so that they would fund it, but it was outsourced to the private sector. They considered that what we were offering was too institutionalized, so that they'd separate aged care from healthcare, different ministers, different lines of governance. Health is managed by individual states. The federal government takes responsibility for aged care. And they really started to push that aged care was more a social model of care and didn't need the regulation. And there was a really nice quote in this Lancet article by a professor of health services research at one of our universities that said, basically, when we turned aged care into social care, we were able to justify not having good infection control measures, not having good staff ratios, and not having adequately trained staff. And so it was really a perfect storm waiting to happen when COVID-19 hit. Next slide, please. And I think this quote here really sums up what happened. we didn't have enough, there were not enough workers to start with. The workforce that does exist doesn't have the training in the contemporary aged care system. They're not equipped to manage disease complexity. They're not equipped to deal with the ethical human rights issues. So then COVID arrives and there are not enough staff who don't know what they're doing, and staff who haven't been trained in infection control. And so that came from one of our top professors in health law and ethics at Melbourne University, Monash. Next slide, please. So, you know, we have done exactly the same as other places now. We've had large public inquiries. We've had new policies put in place that say every nursing home has to have infection control staff. But we still haven't, I think, really grasped the complexity of the problem and where we will actually move forward with infection control in nursing homes. So I thought I'd take a different slant now for the last minute or so of my talk and just think about what we know from our research in hospitals that's been undertaken in Australia. And I think this will really help us address our problems moving forward in aged care. Firstly, we need to improve surveillance. We do not have an NHSN in Australia for our hospitals or for our nursing homes. So all the data I presented was really ad hoc reporting of outbreaks to individual state health departments. So we don't actually have a measure of a map with dots on it to actually see what's actually happening. Likewise, we don't have process indicators around hand hygiene or information around stewardship from point prevalence surveys. We do that well in hospitals now. We need to move that more into aged care. It's starting, but it needs to be more coordinated at a national level. We really need to look at staffing levels and ratios, but we also need to think about the scope of practice of our IPs, because what we know from our workforce surveys of the IPC workforce in Australia is that there aren't many infection preventionists. They're an aging workforce. Many of them are thinking of retiring in the next 10 years. And they actually have multiple jobs and wear multiple hats even within the hospital system, and very few of them work in aged care. So we need to think about that before we say we just need to mandate more staff. Where are they going to come from? We also need to provide more incentives for people working in infection prevention to undertake that credentialing, because as Dr. Pat Stone just presented, staff that who are credentialed actually are able to undertake higher level of competency, and that reduces infection risk. I just really like to highlight that policy is really hard to implement, right? So we found that in our hospital research, and I think it's going to be even more the case in aged care. So even if we might have 20, 30, 40 policies, like some of the other speakers have mentioned, what can we actually get into play and practice? And particularly if we don't have the leadership and the resources and the infrastructure. And that leads into my last point around considering context. Every nursing home in every state will be different, and we need to allow that flexibility for implementation to occur effectively. So that's my take-home messages, and I'll be really interested to take some questions later on in the panel.
Thank you, Dr. Hall. And now we're going to hear from Dr. Anucha, who is at the Thammasat University Hospital. I'm not sure if I pronounced that correctly or not. But you're going to share your screen, so we'll just let you get set up. There you go. All right, take it away. It looks great.
Okay. Thank you, Elena, for a kind introduction. And my assignment is to talk about infection control for nursing home in Asia. And with that, over the next 6 minutes, this is my objectives. First, I would like to start by saying that the perception of nursing home in Asia is not so popular, because if I have to care my dad and mom who get sick, I would prefer caring them at home instead of at the nursing home. But the nursing home by itself has gained more popularity over the past decades. And there are a lot of new nursing home building in many Asian countries. And there are a lot of activity integrating in the nursing home as well. But if you look at the data on the willingness to enter the nursing home facility among the older adult, you will start to say that things that is quite unique for Asians, because first, if you are adult in China, for example, in the study, only 11.9% will be willing to enter the nursing home when they meet the medical criteria for admitting for the care. Thus, home and community-based care should still be considered as the main pattern in aged care system. And this is quite unique for Asia. Even it is the data in year 2017 that is representing the point that I tried to share with you at the beginning. Look at the epidemiology of infection at the nursing home. First, I would like to share with you that if you look at the data on Korea, this is the data suggesting that comparing to community-acquired pneumonia, the nursing home acquired pneumonia will be likely to have more severity of illness, more MDR pathogen, and more associated mortality associated with it. And of course, the nursing home is one of the factors that are causing a prolonged length of stay in the hospital as well. As a lot of previous speakers mentioned, the quality of care of the nursing home has been linked to the degree of the nursing that they graduate and the year that they underwent training, and also the commitment for training in the nursing home as well. As a consequence, nursing home is a reservoir in many Asian countries for many MDR pathogens, including MRSA, and in Asia, we have a lot of gram-negative pathogens in nursing home that become very violent and resistant, including MDR Acinetobacter, MDR Pseudomonas aeruginosa, and carbapenem or CRE pathogen has been reside in nursing home resident and reservoir in the hospital as well. Not surprisingly, nursing home in Asia has been associated with many outbreaks, including many bacterial outbreaks that you see here, a lot of foodborne outbreak, a lot of viral outbreak, including norovirus. Even COVID by itself has been reported to occur as a cluster in Japan, where this issue has been linked to the poor antibiotic stewardship program that has not yet been integrating in any nursing home in the country formally. Next, I would like to share with you the strategy for containing infection in the nursing home. And I would like to start by saying that I try to search for the guideline in Asia. And the one that I can see is the Hong Kong guideline that they put on the guideline on preventing of disease in nursing home in Hong Kong. And in chapter 4, they specifically detail the infection control measure in the long-term care facility that lists a lot of interesting and important items in here. They also come up with a general measure to prevent and control the transmission of MDR in a nursing home, and they also come up with a nice risk-associated metric to differentiate the MDR carriers from those who without risk factor as well, to have a proper management on the infection and MDR pathogen here. Hong Kong is the country that have a very high commitment to the care of nursing home. And this is the serial cross-sectional study that performed from year 2005 to 2014. And I would like to share that even though the metric here that they measure may not be statistically significant, but there is a gradually increase in the trend of practicing a good infection control. And also the availability of the resource, the type of negative, the type of isolation area, and also infection control related record, as well as the staff that passing infection control skill test. Likewise, Taiwan has come up with the educational featuring program to implement the hand hygiene in the national level. And they claim that with the educational and the guideline featuring intervention, they are able to achieve a significant improvement in the hand hygiene in the nursing home in a national level, as well as associated with a significant reduction in nursing home acquired infections. In Japan, it is quite unique that mainly they use the vaccine that has been published extensively as the vaccine by itself is very effective to prevent influenza transmission in the nursing home. Last but not least, this is my last PowerPoint to share that there are some adaptation in the nursing home. And as you all know that the COVID came from China first. And early on into the COVID epidemic, Chinese did not adapt the active surveillance screening, but they do have some modification on the accepting criteria to the nursing home, including the check for temperature, the record for traveling to Hubei at that time, at the early on in the epidemiology, and also the history of disease and the history of contact to animal. And once they did not have these, they will be allowed to get into the nursing home. And also this issue has been gained a lot of attention in many countries in Asia, including Taiwan and Hong Kong, that also come up with the guideline for COVID in the nursing home later on. With all together, I would like to say that despite the popularity of nursing home and in Asia in the past decade, there are a lot of things that we have to learn and study on, particularly on the resource, on the personnel, on the intervention to improve the quality of care, as well as the policy and regulatory. And with that, I would like to thank you very much for your attention.
Thank you very much, Dr. Anucha. And for our final speaker for tonight, before we go into our conversation, we have an infection preventionist himself, Stephen Schweon.
Hi, everybody, and thank you also for the opportunity to present COVID-19 and infection preventionist boots on the ground perspective. Next slide, please. The objectives for tonight: define what an infection preventionist is. We've been talking about that all evening. Describe the boots on the ground approach for mitigating the COVID risk. And 3, summarize the importance with maintaining the non-COVID activities to prevent infection. Next. So what is an infection preventionist? Well, IPs help to ensure healthcare workers and patients and residents stay safe and prevent infections. Now, some of our non-COVID responsibilities include looking for infection patterns, surveillance, data collection, assessing workflow practices, education, both our self-education, educating our residents, our patients, as well as our coworkers, advising leaders in public health, engaging in committees. Next slide. Ensuring correct isolation precautions. Is it droplet? Is it contact? Managing and preventing outbreaks, promoting hand hygiene, ensuring proper PPE use, encouraging resident and staff vaccinations. Next slide, please. Continuing with our non-COVID activities, developing policies and procedures, partnering with public health, regulatory bodies, et cetera, assessing environmental health concerns, collaborating with antibiotic stewardship efforts, pandemic, the next one, and emergency preparedness. And I say the next one because many of you know already there's been avian flu in humans in Asia. And right now we're dealing with a mutant COVID virus starting in Denmark and Canada, in the United States, interaction between minks and humans. So who knows where this is going to go? Next slide, please. There is a plethora of resources that are available to us for our education as infection preventionists. The CDC offers an excellent infection preventionist course. Full disclosure, I've taken it myself. Professional organizations such as FAPIC and FSHEA also offer excellent educational training and resources for folks to become IPs. Next slide, please. Now, what does boots on the ground mean? Boots on the ground refers to ground troops who are on active service in a military operation. And during WW1, boot meant a soldier. And the picture on your left is my father, who was in the Army, also spent time in a nursing home. The picture in the middle is my wife's dad, who was also in the Army, spent time in a nursing home. And actually, several years ago, we had to take him out of the nursing home for multiple reasons, and he now resides with us. And that's me, 3 o'clock in the morning in the Army at Fort Detrick in Frederick, Maryland. And I also have worked in the nursing home as an orderly back when they were called orderlies, as well as an infection preventionist. Next slide, please. So let's talk about COVID-19 meets the long-term care IP. The regulatory body says that the facility designate one or more individuals as the IP who are responsible for the facility's infection prevention and control program. Well, the word designate is very interesting. Did we assign responsibility? You do it. You do it. Do you ask for volunteers? Do you create a new position? And unfortunately, most of the long-term care IPs I have encountered have been asked to assimilate the duty. And clearly, if you have a passion for this, if you like it, your program is going to be far more effective than being told, starting today, you are the infection preventionist. Next slide, please. Now let's talk about the COVID-19 responsibilities as far as being boots on the ground. Well, clearly you're tracking COVID-19 cases, you're reporting to regulatory authorities, you're helping to prepare your facility for the COVID-19 vaccine, promoting PPE and hand hygiene adherence, developing competencies, you're assisting with screening for COVID-19 at the points of entry, creating policies and procedures, you're rounding in the environment. Next slide. I know I got 6 minutes. What you're looking at is several 6-packs of soda. And what happened is the family brought the soda in and the facility would quarantine the soda for 24 hours to make sure they weren't bringing COVID in. But if you look carefully, that's a sofa. And having a sofa is not really conducive to social distancing and keeping people 6 feet apart from each other. Next slide, please. We also follow CDC and Department of Health guidance. And many of you noticed already that the CDC several weeks ago released a really nifty COVID ICAR facilitator guide. They did a terrific job pulling everything together for ensuring proper COVID strategies. Next slide, please. We also help validate social distancing, and we're pretty good with inside the building, but what about the smoking areas where people congregate? And during environmental rounds, I happen to come across an alcohol-based hand rub dispenser in a smoking area. And on first thought, you're thinking, this is great, the smokers can clean their hands. The problem is if they clean their hands, they have alcohol in their hands, and then they go to ignite the cigarette, their hands may catch on fire. Some of our other boots on the ground responsibilities include COVID-19 laboratory testing, fit testing, tracking the news, both locally as well as nationally. We assist with visitation guidelines. We assist with bed management, cohorting, and of course, the normal responsibilities coupled with the COVID duties. Next slide, please. And clearly, understandably, there's only so many hours in the day, and sometimes we get super focused and we may develop tunnel vision, and we may miss out on other things that are going on within the facility. Next slide, please. Well, it's very difficult as we target 0 infections to keep up with all the non-COVID responsibilities that I've discussed, as well as the COVID responsibilities, and still target 0 infections. Clearly, we don't want to see anybody getting a CLABSI or a CAUTI, developing C. diff, or seeing increased MDROs in our facilities, besides seeing increased COVID. Next slide, please. So during environmental rounds, as I wrap things up, I'm in a soiled laundry, soiled linen area, and I came across this cooler, and I was befuddled. It makes no sense to me. Are they eating in soiled laundry area? Are they drinking in soiled laundry? And then I started to think, are they bringing in their alcoholic beverages of choice. So with some fear and trepidation, I opened up the cooler, and clearly you can just see ice. And of course, the staff denied any knowledge whatsoever of this cooler in the first place. Next slide, please. So in my 6 minutes, I'm hoping nobody fell asleep and you hung in there with me. Next slide, please. This is my office, which I'm sure mimics many of your offices. I want to thank you for your time. I appreciate any questions that may be forthcoming. You have my email, and I respond to all email questions and comments. So thank you very much for your valuable time tonight. Alana?
Thank you very much, Stephen. And thank you to all of our speakers for really your wide-ranging and thought-provoking presentations. I will now ask each of you to turn your camera on as well as unmute yourselves so that we can have a conversation. Thank you. So before we get to the key takeaways, I just want to ask anyone that wants to, if you have any comments or questions about the other presentations that you heard tonight. Did anything stand out to you? Was there anything that you were surprised by? Anything that you might have a different perspective on? So we won't go in order, but if just anyone wants to share for a few moments, please do so. Go ahead. Yes, Pat.
Okay. So Lisa, I was surprised at the very high level of deaths in aged care in Australia. And I don't know if you want to comment on that, or, it's very different than the 42% in the United States, 75% of the deaths being in Australia.
Yeah, absolutely. I think it completely shows the dichotomy of how well we were set up in terms of public health, but how we'd let aged care become too hard of a problem for too many years. And there's been inquiry after inquiry, and people just passing the buck virtually and not really wanting to take responsibility for infection control in nursing homes for many years. And then COVID-19 hit. And interestingly, we already had what we call a Royal Commission, which is our highest level of national inquiry happening on aged care. And that had been going for over a year with really devastating testimony from residents and families and clinicians around how bad the situation was in aged care. And yet we still weren't prepared for when COVID hit. And it really does come down to the basics. We got the basics wrong. We didn't support the staff enough. We allowed staff to really be employed casually and work between nursing homes. They didn't have good infection control training. There was PPE available at work, but it wasn't the right PPE, and no one was fit tested, and no one knew what to use when. And the communication just broke down. No one knew who to contact, and the families were really shut out as well. And they was waiting outside of nursing homes, knowing that their parents and their loved ones were dying inside and couldn't even find out what was happening. And the government basically decided, I will just send virtually the army in, which wasn't the right thing to do either. And it just spiraled out of control.
Thank you.
Anyone else want to comment on other presentations? Go ahead.
Yeah, I also was struck by something that Dr. Hall shared, which gets at the business aspect of long-term care, and that shift I think you mentioned from a more public healthcare model to a more privatized. We're seeing and have for some time in the U.S. seen a shift away from not-for-profit mission-based and a growing proportion of for-profit entities and a complexity of kind of financial paradigms, I guess, for lack of a better word, for the way nursing homes are managed, sort of at the highest levels in terms of shareholders, stakeholders, and so it just, I think, it speaks a little bit to how important it is to reinvest in these places and put the residents at the front and put the staff at the front of all of the decisions, right, about how resource allocation is being made. And I think that's a challenge. sometimes in certain models of business, frankly. So it was just striking that the commentary you mentioned kind of caught my eye.
Yeah, and that's certainly what we've been reflecting on. And I think it'll be interesting moving forward whether legislation and accreditation requirements can help that. And I think there's an in-between step that we're not really grasping. But yeah.
Anyone else? Comments about Dr. Hall's presentation or anyone else's?
I was interested in the Thailand and Asian experience, actually, and this thought that there's been this cultural shift and more people are actually going into aged care, because traditionally we've always believed that just culturally, most people try and keep their families at home, but that you are seeing more of these medicalized type models and aged care becoming more common. So that was, it was interesting just to see the parallels. We're all facing the same problems, and we're all facing the same issues around staffing and common multi-resistant organism infections. And, we talk about, yes, the next pandemic might come, as Stephen said, from minks, but I'm thinking AMR is already our next pandemic on the radar. And what are we going to do in the next 10 years with that?
So actually, if I have to say, I still prefer take caring of my parents at home, not the nursing home. But in some situation when the kids cannot handle the situation of care, they may opt to move their parents to the nursing home. But that is not quite common in our cultures, because in the culture by itself, I think, including China, that I sharing with you the data, that the willingness to go to the nursing home is fairly low. So this is quite unique to the Asian cultures.
Can I ask another question? The pictures you showed, Dr. Anucha, if I said your name right, the pictures you showed looked so different to me as a nursing home, because they were these, like big wards with beds in them. Is that sort of the nursing home that you would have there?
Yeah, because the idea is that, as I mentioned, it is part of the culture. The kids will send their parents to the nursing home only if they cannot handle it at home. So the concept of that is kind of like the hospital, not like nursing home in the traditional sense in the West.
Just so different in terms of infection control measures, though, isn't it? Because I'm just thinking of those other photos of coolers and ice and random sofas. Well, you don't have that when it looks like a hospital ward. Our biggest issue is always carpet. How do you deal with carpet and trinkets and family photos? And yeah.
Yeah, that is interesting. I think the country that do a lot of work on the nursing home is Hong Kong, like I mentioned to you. And they model a lot of infection prevention measure from US. And they even invite the US speaker for the workshop as well. So I think there are certainly, there are a move forward the future for care in the nursing home in Asia, and it's will gain more popularity in the years to come.
So in the last few minutes, before we go to the questions from the audience, I just want to ask each of you to share one key takeaway from tonight or today, depending on where you are, that you think is important for those watching to advance our understanding of infection prevention in nursing homes. And just to make it easy, I'm going to go in order of who presented. So we'll start with Dr. Nimalie Stone.
So again, thank you all so much for these incredible, accounts of the experiences across the world. I think it is very clear that we are all facing very common challenges. And the other thing that resonated for me during this session was really not very much of this is new. Like these challenges that we're facing, and Pat showed all of this historic data about infection prevention programs and resources and staffing challenges. They just kind of became, the cracks in this, in the infrastructure that this virus took advantage of, and my hope from this experience is that we transform our industry to shift and really meaningfully change these challenging issues and address the underlying problems of staffing and resource allocation. And that to me is the only possible silver lining from the experience in long-term care across the world. Thanks.
Thank you. Pat Stone.
Thank you. I too want to thank you. And it was very interesting to hear about the devastation and heartbreaking to hear about the devastation that's happened across the world. I agree with Nimalie, and I hope for the silver lining to be improved processes. I worry about that the nursing home is not just that we need to put the goals of care and have resident-centered care first and foremost. We all obviously need to have infection prevention, and we cannot have this transmission. But how we manage infections, we need to think about what are the right goals of care for that person. And it could be different for everybody. It needs to be individualized. Because I do believe that we need to have comfort care and recognize what these people want and what their families want. And I guess that's it.
Thank you. Dr. Hall?
Well, I concur with both what Nimalie and Pat have said, but my other big take home from this was the real power of having the data to actually track what's happening. And also I'm hoping that that data will, over time, if we get the systems right, help us see what's working and what's not working in terms of policy change and interventions and vaccination, and when that actually hopefully will start to see this. And without that good, and this isn't, I am an epidemiologist, so you may expect me to say the data is key, but I do think that helps us explain what we're seeing. And it's a combination of that contextual qualitative information with the good solid informatics around what's happening on the ground that will help drive this forward.
Absolutely. Dr. Anucha.
Completely concur with Dr. Hall, and I think in Asia we probably need a lot more data on resource, personal, intervention, and also policy and regulation, because we are at the very beginning stage of the nursing home care for the futures.
And Stephen.
Just a few random thoughts. I like the saying, it's not how you start, it's more important how you finish. This virus is going to be around for quite a few years, despite what the politicians say, and it's a marathon, not a sprint. Take one thing at a time. Equanimity is a huge word for me, just staying balanced and centered, seeking assistance, trying to get help whenever you need it. And there's a tremendous amount of resources that are available to people. They just need to pick up the phone, email, but there's plenty of help to assist with this huge burden.
And I think having us all together is one example of that. Clearly we're, struggling with it from all different parts of the world, but we can also share resources, ideas, and best practices as well. So thank you all. We have about 15 minutes left, and we have a lot of good questions. So we'll see how many we can get through. The first question is actually from our partner on this project, Dr. Carmen Portillo, who's a professor at the Yale School of Nursing. And she said that, in this summit, we really covered a lot of high-level issues. And the next part of this project, after the summit, is that the Yale School of Nursing will be developing a toolkit for nursing home staff, specifically on infection prevention. So if you were writing this toolkit, what would be your top priority tool that would really need to be created for nursing homes as part of this toolkit? And anyone can answer.
I was thinking about this a little bit. When I saw that question, I think it's a really important issue. What do we do you know, at the ground level, at the bedside, right, to make meaningful change. And something that I've seen emerge when I get to visit facilities and talk to providers, I learned from one center that they had identified an infection prevention champion for every shift. And they, you know, it really, you know, we talk about the infection preventionist, and they are critical resources, but they can't be somewhere 24/7. No one person, right, can own this program. And I think the shifting our mentality to get that recognition that every single person in the center has a role, has an ability to improve safety. And so I'm going to say one of the tools that I really would like to see taken effect in nursing homes, the way we've seen it in hospitals, is the auditing of infection prevention practice at the bedside. Quick, easy ways that when someone like Steve walks around, but it could be any colleague walking around, they know what they're looking for, and they can provide that peer coaching, that quick, just-in-time feedback. That's not culturally built into nursing homes yet, and I think that is critically important to translate policy into practice.
Yep.
Building on
Yeah.
that, go ahead, either way.
No, I was going to add to that. In a way, I think that that's really vitally important, but I also think it's that next step around some quick and easy risk-based interventions. So it's not one size fits all. So it's not like, let's lock everyone in their rooms and no one can talk to each other and no one can have visitors. And, you know, it seems like we're putting nursing homes in this category of there's either no interventions or there's full lockdown interventions, and there's not this balance around actually what the real risk is and how you can take that kind of risk-based approach. So I kind of add that auditing, like a risk assessment tool to that. And my other tool that I'd add is my other things would be a template for a communication strategy for the facility, because quite often they're so focused on solving the problem straight in front of them, they forget about the families and the government and everyone else out there that wants to know what's happening. So a kind of a comms checklist, I suppose.
Those are great ideas, really great ideas. You know, I think the communication, I've heard the communication strategy of where they're getting their information, who they're reporting to, as well as how they're giving information to families. That's really key. As far as everybody should be involved in infection prevention. And I think we need the toolkits to audit, but we also need the education to teach people, and you know, how to teach them. And if the person delivering the trays doesn't know about infection prevention, or the person that's doing the cleaning of the rooms doesn't know about it, you know, everybody needs to be educated, and then audited. That way, you know, so they can get better. So I think, Carmen, I would think that we need educational tools as well as the auditing tools later, as well as good communication strategies. In an outbreak, we also need good advanced care planning.
I mean,
for all the time.
I need to disclose that I have an aberrant sense of humor, and I would consider having you putting some humor into the toolkit. And here is a great example. The CDC several months ago put out a poster with how not to wear a face mask. You don't wear it around your ear or as a chin warmer. This was brilliant. This was brilliant. And if you can have some fun with your educational tools as far as teaching people what not to do, I think it'll go a long way instead of wagging your finger at them and trying to slam education down their throat. So if you can, try to have some fun with the whole concept. I think people will be far more receptive to it.
Co-design is so important, and we know that from the work that we've done with hospital cleaners in the past, that you can't just tell them what to do. You've got to work with them and see it from their side, and that humor and touching a nerve, I think, is so important.
And just to add to Stephen's point, I know from some work that we're doing at NIAM, there are some very effective, colorful, and somewhat humorous videos on infection prevention. So there's a lot out there on YouTube. You can email me, I can send you some. So I think also having like a multimodal and kind of just more lighthearted approach can just make it easier to digest.
I don't think we need another version of the hand hygiene dance, though. I think we've seen Didier
Oh, I
too many
haven't seen
times
that
do
one.
that. Oh gosh, we'll send it to you, Alana.
Okay, please do. So I just want to switch gears now. So I imagine a lot of us, maybe some of you, I know I certainly do, and I'm sure many of our audience have loved ones that are living in nursing homes or in other types of communities, resident communities. And so Lindsay Goldman asked a question about how do we kind of balance protecting these residents with also making sure that they can socialize both with each other and also with family. How do you, I know it's, we're not gonna be able to answer that in 2 minutes, but what are just some kind of quick ideas about how the director of social work and the director of nursing can really, and other staff can just make sure that the residents are staying safe while still staying connected?
We need testing. We need testing, we need testing, we need testing, and we need, reliable testing. And we need to not have community spread. I mean, my community, the community spread is so high. So, it's, I think we need that first, given that the community, putting people in at the end of their life. Matter of fact, I remember the Scottish man that was on the other one, who said he got a call from a 108-year-old person that says, I don't have another year. I need to see people now. So we need to find a way, and that just, breaks your heart. But we need to find humanitarian ways to make sure that people are getting the needs that we can, whether it's iPads. I've heard about nursing homes that they don't even have a phone. They don't even have phones to call people, and so we need staff to help people with their phones or their iPads, there's just so much we can do. And we need to give resources for it.
Anyone else? Oh, we can't hear you, Nimalie.
Individualizing the interventions, and Lisa talked about a risk assessment. I worry, that we do these very aggressive, broad-reaching approaches to safety, but they're not sustainable. They have a downside and an adverse impact on people's, not just quality of life, but their actual health and wellness as well. I mean, people are, there's a very high rate of deaths among individuals with cognitive impairment, and there's a very high rate of depression and failure to thrive. These are from isolation and loneliness. And so how we have to trust everybody's going to be taking responsibility for their actions. And, we all need to kind of contribute in that sense as a community, but it really does seem like we can tailor some of our interventions. We know much more now about how this virus is spread, and the places that are high risk and the things we can do to be protective. So it takes a lot of thought to create an environment to start to open up some of these social interactions again. But I think it's feasible, and we're certainly trying very hard to help, support centers that are taking those steps.
Yeah, absolutely. In the interest of time and it being 9:30 p.m. for many of us, I'm going to wrap it up. And I just want to thank, of course, each of you for sharing your knowledge, and it really reflects the work that you do every single day to help keep long-term care residents and staff safe, and in turn, by extension, all of us during this very challenging year, I think for all of us, and I'm sure all of the audience as well. Just a reminder that we will be posting the slides and the recordings of both today's presentation as well as the one we had last week on our website. Everybody who registered for this event will get an email once that web page is ready and up. You can also go to niam.org/events for more events that NIAM hosts on related topics and other topics related to health equity. And you can follow us on Twitter. We have both a Twitter handle for the New York Academy of Medicine, as well as for Age Friendly NYC for the work that we specifically do at the Center for Healthy Aging. And once again, I want to thank the Saraya Company for making this event possible. I want to thank the Yale School of Nursing for working with us on this project. And I want to thank all of you for joining us. And I hope that you get home safely. Have a good night. Bye-bye.